So I don't know how much more helpful these are than just reading through the answers on the self-test, but I thought I would make a video just because sometimes hearing and reading at the same time is a much better way to get things into your brain. And I think it's a high priority that you start working on multiple choice. So about 34 questions here, and again, probably about 8 to 10 of them will be on the actual test. These are obviously tougher questions too. Which of the following statements about JG cells is incorrect? So again, you want to emphasize that word incorrect. They sense stretch. Yeah, that sounds good for a JG cell. They sense stretch to detect blood pressure. They do play a critical role in regulating blood pressure. They do secrete renin, so they have large granules to do that. They respond to sodium changes in the filtrate, and that's not true. That's what MD cells sense. JG cells sense stretch. MD cells sense sodium. So this one is one of the reasons I really like A&P2, because you keep connecting as you go. You keep building your understanding. So this is respiratory content, but now we're going to add in things like pH. And also, how does that change in pH affect potassium? And how does that potassium affect neurons in the brain then? So low CO2 will decrease blood flow to the brain. That's true. Maybe the easier way to think about that is if your arm is working out and you're increasing CO2, then you're going to have increased blood flow. But if you're working out your arm some way and you're really going to relax it and it's not working very hard, then you decrease blood flow because you don't have a buildup of CO2. So in the brain, if you're hyperventilating and you're getting rid of CO2, then that's going to decrease blood flow to the brain. That's going to decrease pH. And that's going to decrease the Haldane effect. Remember, the Haldane effect is one of the ways we kick oxygen off hemoglobin is with CO2. And if there's less CO2 around, we're less likely to kick off the oxygen. So in patients, this decrease in O2 can cause a number of physiological effects. And this is just the video to the pilot. And the pilot thing was the reason why I got banned last time, or why my video was taken down. Thus, in hospital situations, it's important to manage pain to avoid hyperventilation and reductions in CO2, because neurons will hyperpolarize and change behavior, and you can't always predict how it's going to change. Let's go with decreased CO2 is going to decrease acid, and that's going to decrease potassium. So this is going to cause hypokalemia, and hypokalemia will cause neurons to hyperpolarize and change behavior. So this goes all the way back to the beginning of A&P2. If a client has acute renal failure leading to hyperkalemia, what specific symptoms might be monitored? Now, I'm always trying to be honest here that the logical thing that would happen here is that it would cause changes to the QT interval. Logically, it would increase the duration because it would take longer for potassium to leave the cell if there's already a lot of potassium outside the cell. So those potassium channels that repolarize, they'll actually repolarize faster if they sense there's a lot of potassium outside the cell. And that's why I just made it kind of changes in the QT interval rather than say it shortens the QT interval. The nurse is instructing the client with chronic renal failure. So chronic renal failure is going to cause a change in fluid and also nutrition, getting rid of waste. So which of the following diets would be most appropriate? Well, it's hard on the kidneys to get rid of protein. And so that's pretty damaging because those holes in the filtration membrane are right about the size of a protein. So if you eat a lot of protein, that might plug some of those holes and it's going to reduce renal ability even more. Also, one of the big things the kidneys does is it has to get rid of extra sodium and get rid of extra potassium. You don't want the kidneys to have to try to do that if they're already failing. And so that's why you'd want a low sodium, low potassium diet. So this one's an interesting one. I brought it up in class, or I brought it up in the connections video, that 10 years ago we didn't really associate dementia, or delirium is probably the better term, for short-term changes in cognition. Select the options below that seem least logical. There is the theory that the pain associated with UTIs lead to distracted thoughts, and that's called the cystocerebral syndrome. But it's more likely that's what actually happening is because of less drinking of water in old age, because of also a weaker immune system, you have a bacterial infection, you have a UTI. And that UTI is going to be caused by weakening of the immune system with age. That bacterial growth is going to break down electrolytes and things like that. And so that's going to pull water into the urine and are enhanced due to and so again, they're decreased hydration. So the three things that are there are a weaker immune system. Bacteria are going to cause water to flow into the urine. That's going to dehydrate. And then elderly already have a decreased sense of thirst, so they already tend to be dehydrated. So this is probably an unfair question. It actually comes from the NCLEX, an NCLEX board review book that I had, and I just found it interesting that you have to, obviously, when you're in nursing, you have to, or any kind of healthcare, you have to prioritize things. And so if you're in acute renal failure, you have to worry about fluid building up in the lungs, and so your first thing to do is to elevate the head of the bed so this increased fluid doesn't fill the lungs. It's that kind of typical airway breathing, circulation. I don't remember what the D and ERE is like, exposure. But so you're definitely going to worry about edema, but that's not your first thing. Your first thing is going to be elevate the head of the bed. High carbohydrate, kind of did one like this before. A high carb, low protein diet is prescribed for the client with acute renal failure. It just takes it easy on the kidneys, so then you don't get ketosis by breaking down too much fat. You also don't get as much urea because you're not breaking down as much protein. So that's why a high carb, low protein diet is easier on the kidneys. So this one also goes back to respiratory fluid in the lungs. Why do we care about fluid in the lungs? Because it's cohesive. It makes it harder to increase the size of the alveolus, so increase volume, which means you can't decrease pressure. And if you can't decrease pressure, you can't breathe in, and so inspiratory capacities will be reduced. I love how AMP2 really connects the heart, lungs, and kidneys. If a cell is put in a solution that has a greater concentration of solutes, so the inside of the cell is more concentrated, the solution has a greater concentration of solutes, so this is hypertonic. So then water is going to move towards concentration and leave the cell will shrink. And you've learned about that early in AMP2 and early in AMP1, but we also try to extend that to something in AMP2, which is if that cell shrinks, everything's closer together, and so chemical reactions speed up. And at 400,000 chemical reactions per cell per second, that speed up is going to matter. It's going to have consequences. So these are ones that we did a little bit on the PowerPoint or the Prezi, but I'd really like you to think through these. So I would say a person with acidosis, and I would recommend don't read any further. A person with acidosis has high CO2. They should be breathing rapidly to get rid of that CO2. Okay, they are breathing rapidly. That means the respiratory system is doing the right thing in this situation. So the problem is not respiratory, it's metabolic. And of course it's acidosis because I told you it's acidosis. Client with acute renal failure has an increase in the serum potassium level. The nurse should monitor the client for, potassium is a big weakness for the heart. It causes changes in the heart rate and also heart contractility. It affects how much calcium can get into the cell and therefore cause the heart muscle to contract. So of the things that are pretty important there, C is pretty good, but that's going to start first with cardiac arrest. So cardiac arrest is probably the best answer there. Person with alkalosis, again here, alkalosis. So that means they have low acid. That means they have low CO2. That means they should be breathing slowly to get that CO2 back up. They are breathing slowly to get that CO2 back up, so it's not the respiratory system that's the problem. It's metabolic. And it's alkalosis again because I told you it was alkalosis. Person with acidosis, okay, they have high acid. That means they have high CO2. They should be trying to get rid of that CO2 by breathing fast. They are not breathing fast. They're breathing slowly, and so that means the problem is respiratory. Respiratory is causing the problem. I really like this kind of question because, again, I really like to emphasize simpler things because one of our goals is to simplify the complex. And there's some things that just look so complex, like edema, also hematocrit, anemia, and things like that. Edema can be broken down pretty simply because we broke it down into it's caused by an increase in HbC, which is blood pressure, a decrease in the ability for the liver to make albumin, whether you don't have as much protein to be a building block or the liver can't do it. And then also you have damage to the capillary, and then a problem with the lymphatic system. Now, I don't like this question as I read it because I'm not figuring out why D is not a good answer too. All of the following would cause edema except hypotension would not cause edema. Hypertension. Hypoproteinemia, well, you wouldn't have as much protein to draw the fluid back in, and so yes, that would cause edema. Liver disease, liver disease, you wouldn't be able to make the albumin, therefore that would not cause edema. And incompetent venous valves would cause edema. So B, C, and D all do cause edema. A does not. Low blood pressure does not cause edema. The other three do. So this one looks pretty NCLEX-like. Client's serum potassium level is elevated in acute renal failure, and the nurse administers sodium polystyrene sulfonate. This drug acts to increase potassium excretion by the colon. if you have too much potassium, you do not want to increase hydrogen because that would increase potassium even more. Calcium, that would increase potassium more. And if you exchange sodium for potassium ions in the colon, that means you're going to take up more potassium. That's going to do the wrong thing. So you could have got at this just by realizing B, C, and D are going to increase potassium. But increasing secretion from the colon, then that's going to get rid of potassium. Another way to get rid of potassium, and this one is due to Mr. Coffee pointing this out, is that if you give someone insulin, then that tells the cell to use the glucose-sodium exchanger to take up glucose into the cell, which means you're getting more sodium inside the cell. So that's going to upregulate sodium-potassium exchangers. And so now you're going to start pumping more sodium out of the cell because the glucose transporter was letting it in. And that means you're going to pull more potassium into the cell, and that's going to decrease potassium. Pretty cool to just kind of figure out those kind of simple logistics of what's the sodium transporter doing, sodium potassium ATP is doing, what's the sodium glucose transporter doing. So again, by increasing insulin, it tells the cell to take in glucose as well as sodium. When there's extra sodium in the cell has to pump that sodium back out so the VM doesn't change, and it uses a sodium-potassium exchanger to do that. All right, so this has been a few years, but there's a kid in Cedar Falls, Iowa, so just an hour and a half north of here, lost their sense of thirst, and it seems like that's going to be a pretty big problem at some point if you don't have that sense of thirst. There's other mechanisms, but that's the best way to tell you, hey, I need to increase my amount of water. So which of the statements seems most logical? Damage to the hypothalamus is very rare because most damage to the brain is in the cortex. I just like pointing this out as a neuroscientist, that we think the outside of our brain is prone to damage because we can get hit on the outside of our head, but the underside of the brain is also prone to damage because your brain floats, which means if you concuss your head or you move your head too much or you get hit on the top of the head, then the brain can hit the bottom of the brain on the base of the skull, and that can cause damage to the pituitary and the hypothalamus and the hippocampus and things like that. So I guess B explains that because the brain is floating, the underside of the brain can easily be damaged by trauma. A lot of people in car accidents too, they lose their sense of smell because the brain is pushed forward as they stop quickly, and that rips off the olfactory bulbs. Because of the positioning of the circle of Willis, areas around the diaphragm, so that's the blood vessels on the bottom part of the brain. Areas around the diencephalon, so that's the middle brain, are prone to damage from salts that enter. Yeah, that's true. That's actually true. Infection is able to enter the inferior portion of the brain due to the holes in the cribriform plate. Those holes in the cribriform plate are olfactory neurons going through the base of the skull to get up to the olfactory bulbs. And it's not real common, but if you are not careful with a neti pot or you swim in certain areas, you can get amoebas up in your nose and they can enter your brain through those little holes in the cribriform plate. So A was untrue. Increasing your salt consumption would have what effect on your heart? This is way back to when we did action potentials in the heart. And again, my advice to you is just keep learning it and keep learning it because there's so many connections. And especially if you go into nursing, probably PT too, because that's kind of a lot of electrolytes. Definitely respiratory therapy. You're going to be thinking about this connection between the heart, the lungs, and the kidneys a lot. So increasing salt consumption, I talked about it as Grandma Betty likes her salty popcorn. That's going to increase the rate of depolarization. So sodium is going to leak in faster to the pacemaker cell, and that's going to speed up depolarization and speed up the heart rate. Looking at the picture above, imagine if someone consumed a great deal of protein. So that means there's a bunch of protein. I mentioned this briefly, and it's kind of a challenging one, but I still like to mention it because everyone knows that consuming too much fat can lead to heart disease. Consuming too much sugar can cause diabetes mellitus. Also, consuming too much protein can damage the kidney, not only because it plugs up the filtration membrane, but even if small amino acids get over here into the filtrate, there are lots of transporters that say we can't lose amino acids. We worked hard to get these amino acids. And so these transporters will transport things across from the tubule into the blood, and that will also create a concentration gradient to pull other things. And so it's the same as having low sodium. It's the same as having low GFR. Eating lots of protein will pull more things over here, which means you're going to keep things you don't want to keep. You're going to pull bad things like urea back into the blood. So additional waste products like urea would be absorbed. And that's why, I mean, it's not as common nowadays, but it's still pretty common that people think they're going to get more swole if they eat more protein. It's a big thing with pharaohs 4 or 5 years ago. Your body does not say, well, I've got more protein, so let me build more muscle. That's not how it works. So consuming extra amounts of proteins is not going to help you. It's going to actually damage your kidney. And we know that too, because farmers for decades, centuries, have been trying to raise animals faster. And of course, one of the things you try is feed them more protein so they can build more muscle. But that doesn't work in livestock. It just damages their kidneys. Of the following, which is least likely? So circle that least condition that would result in protein in the urine. So you can get protein in the urine if you get too high blood pressure, if there's something wrong with the pore membrane. So diseases of the glomerulus where protein passes through the filtration membrane. Yeah, like diabetes mellitus, you can get sugar crystals that damage the filtration membrane. High quantities of protein in the serum. Yeah, you can have protein in your urine if you have a high protein diet. High blood pressure. So sometimes when people are working out, if you were to take your urine sample after you just lifted heavy, those temporary increases in blood pressure when you're lifting can actually push protein through your filtration membrane. Dilation of the efferent arteria allows too much protein to enter the peritubular capillaries. So I think the thing with dilation of the efferent arteriole is that that's actually going to lower filtration, and so that would decrease the pressure of filtration and decrease your likelihood of protein in your urine. So each of these three are going to either increase pressure or increase protein to go through the filtration membrane. This one's going to decrease net filtration pressure, and that means it's going to mean it's less likely to have protein in your urine. Angiotensin II raises blood pressure by constricting blood vessels. This is pretty tricky about angiotensin II because if you constricted the efferent, then you'd filter too much. Or if you constricted the afferent, then you wouldn't filter enough. And so what happens is angiotensin constricts them both about the same, maybe a little bit more of the efferent. And that just really comes down to a cool thing where there's just a few more receptors for angiotensin II in the efferent arteriole than there are in the afferent. And so that means GFR roughly stays the same. This is a similar question. If angiotensin II constricts the efferent arteriole more than the afferent arteriole, this would increase net filtration pressure. That's true. You're not bringing in as much blood and you're not letting it out through the efferent. If the NFP is increased, additional substances may be filtered into the filtrate. Which option represents a logical way that those substances that are filtered under higher NFP may be returned to the blood? Okay, so if you are filtering a lot, then the plasma fluid in the peritubular capillaries get really concentrated. And what that's going to do, if I can flip back. So why I wanted to flip back is because it's the same thing as making the concentration of the tubule more concentrated, which is going to drive more reabsorption. So that's why we're going to increase reabsorption of tubular fluid. So we're going to take fluid from the tubules and put it into the peritubular capillaries. So again, that's when, by cutting off filtration, the filtrate is going to be more concentrated. That's going to push more from the filtrate over into the peritubular capillaries, and so you're going to absorb more stuff. Yeah, constriction of the afferent isn't going to cause the filtration membrane to change its structure. Yeah, and it's not that those higher solutes make the pumps work harder, because pumps just work at one speed. And the additional solute will be lost, but the overall effect is minimal. There's definitely going to be an effect by having too much angiotensin II. Which factor would increase the secretion of ADH? So remember, ADH is released by the posterior pituitary, tells the collecting duct to take up more water. And that's going to be salt consumption, obviously. If you have a lot of salt, both the posterior pituitary and also the hypothalamus are going to sense that increased salt, and they're going to say the hypothalamus is going to stimulate thirst, and the pituitary is going to stimulate ADH. In blood, which of the following would probably not be a solute? Water is the solvent, so it would not be a solute. Which of the following least fits the definition of solvent? Again, blood is more likely to be more of the solvent than the solute, since blood is a lot of water. That's really not a great question. Don't know where I got that one from. Client developed shock after severe MI. now has developed acute renal failure. So this goes all the way back to our CHF case study, which is if your heart is not strong enough to create enough pressure to get the kidneys to make urine, you're going to be in urine failure. So the MI is going to decrease blood flow, and that's going to decrease blood flow to the kidneys and put you in kidney failure. So this is an NCLEX. Nurse is teaching an 80-year-old client with a urinary tract infection about the importance of increasing fluids in the diet. Which of the following puts the client at a risk for not obtaining sufficient fluids? Yeah, I mean, liver function doesn't really have anything to do with thirst. If you increased ADH, you'd be pulling up more water, and so that would not be a consequence that caused you to have a risk of not having enough fluid. Same with decreased production of aldosterone. If you decrease production of aldosterone, then you'll take up less salt, and that will also make you less dehydrated. So decreased sensation of thirst is one of the most common problems with electrolyte balances in the elderly. Common number cited for the chemical reactions in the body. So there's different ways I always state this is 400,000 per cell per second, or 400 billion in the body per second. If a cell is placed in a hypertonic solution, so that means there's more stuff outside the cell, then water is going to leave from the cell to go out. That means the cell is going to shrink. And when a cell shrinks, everything's going to be closer together. And so chemical reactions will speed up. 25% of the blood, so I've been saying this from day one, about 25% of the blood leaving the heart will pass through the kidneys. Why is it going through there? Is it to get rid of waste products? Well, no, because you can go 3 days of building up waste products before it's a major problem when you're in kidney failure. The problem is the lack of electrolyte control. So you're going to lose control of electrolytes, which puts you at a much higher risk, 5 times the risk for cardiac arrest if you don't have good control of your electrolytes. And we've been talking about that all semester and all through AP1 and AP2, how important control of sodium, potassium, and calcium are, especially the action potentials in the brain and the heart, but also skeletal muscle because that drives your respiratory system. If a cell were swelling, ooh, this one's going to be tough. If cells were swelling and chemical reactions were slowing down, so that means the cell is in cells were swelling. That means the cell is in a hypotonic solution, which means you have too much water around. So how do you get rid of the amount of water so that you're not so hypotonic? Well, if you constricted the afferent, then you wouldn't filter as much. So that's not going to help you. Macula densa cells will sense the decrease in stretch. Well, they don't sense stretch. JG cells will sense decrease. Well, they don't decrease. JG cells don't sense sodium concentration. So by elimination, it's got to be constrict the efferent. And that doesn't make sense because if you constrict the efferent, you're going to force more fluid through the kidney and make the kidney do a good job of getting rid of that extra fluid and correcting the fluid imbalance. Okay, so cells are swelling. Those would be swelling because they're in a hypotonic solution. And the cell swelling is going to slow down the chemical reactions. But the main thing here is that you have too much hypotonic fluid outside the cells, which means you have too much water. How do you get rid of water? Send more fluid through the kidney by constricting the efferent arteriole. In addition to nausea and severe flank pain, okay, so this is a small thing that we did with the autonomic nervous system. I don't think I mentioned it this section, but I still want to bring it up now, that the kidneys sometimes refer pain to the lower back or even sometimes the shoulder. It's one of those things where sometimes the body does not read the sensation correct. Like, I don't know. Sometimes in a car, there's not a real problem with the car, but there's a problem with the sensor. And in this case, there's a weird sensor that says if my kidneys are in pain, my back should hurt. So this is referred pain. In response to increased levels of aldosterone is responsible for in the collecting duct. And here's where I'm thinking it through in my head before I'm looking at the distractors, and I would recommend you do that too. Aldosterone is at the end of the renin cascade. It's going to go to the collecting duct and take up sodium. Yeah, so if you're taking up sodium, then urine is going to have a lower concentration of sodium ions. You should associate aldosterone with sodium. It does work on potassium, so I should be careful about that. One of the ways, if you have high potassium, okay, back up, DJ. What aldosterone does is it uses the sodium-potassium pump to pull sodium out of your filtrate. But if it's pulling sodium out of your filtrate, it's pushing potassium into the filtrate. So aldosterone's main job is to pull up sodium, But if this would have said urine with a high concentration of potassium, that's actually true. If you're pulling up sodium, you're probably pulling up water too, and so you're not going to have a large volume of urine. Urine with a lower specific gravity, well, it's kind of tricky, but if you just pull up sodium, then you're probably going to have a lower specific gravity because there's less stuff in there. But usually aldosterone is going to be released, so here's where you'd have an argument. Aldosterone would probably also cause you to take up water, and so that might... Oh, that would increase the specific gravity. It would make your urine more concentrated. Urine with less urea, ADH, or aldosterone doesn't deal with urea. Which of the following statements about AMP are incorrect? So AMP is released by the heart when the heart feels too much stress, and it inhibits the angiotensin II and the renin cascade. So yeah, it suppresses the release of renin. Yeah, it reduces blood pressure because it's inhibiting the renin cascade. It's released in response to stretching certain cells. That's true. It acts as a potent diuretic. Yeah, that's true, but does not affect sodium. It absolutely affects sodium because it's in the renin cascade. It affects the renin cascade. And at the end of the renin cascade is aldosterone, and that works by taking up sodium from the collecting duct. Which substance would not be expected in urine? Large proteins. We filter everything smaller than a protein. Which of the following statements are not true? I like this question because it's kind of a red herring. It produces renin that helps regulate blood pressure. Yeah. It does metabolize vitamin D. Yeah, that's true. It does produce EPO. So if you know the things that your kidneys release, then you know that these are the three things the kidneys release. It does actually carry out a lot of gluconeogenesis. So what gluconeogenesis is when the body makes glucose so that it can make ATP. Technically, the liver does the most of this, but second of all the organs that directly use glucose to make ATP are the kidneys. And the reason is because they need to run all those pumps to pull things back out of your urine and keep them. All right, so that's learning catalytics. Hopefully you'll go through those. I went through kind of fast because I didn't want it to be a real long video, but if you watch this on YouTube, then you can slow it down, or you can always email me questions as well. Take care.